Hello, wonderful people. It's Medicosis Perfectionalis, where medicine makes perfect sense. Welcome back to my cardiology playlist. In previous videos, we talked about aortic dissection, aortic coarctation, as well as constrictive pericarditis. Today, it's time to talk about another topic, which is kind of similar to constrictive pericarditis, but not identical. Today's topic is cardiac tamponade, where the heart is surrounded with a bunch of fluid. Either too much fluid or too fast an accumulation of fluid. But what if the fluid is accumulating slowly and in a very little amount? Then no tamponade will take place. Because believe it or not, your normal pericardium is very resilient. In order for you to cause significant damage that affects the hemodynamics, this accumulation of fluid has to happen very quickly or in a huge amount. So it's either too much or too quick. Smash the like button, subscribe, and let's get started. This is my cardiology playlist. Please watch these videos in order. If you wish to converse with me, said Voltaire, define your terms. So let's define the terms. The word tamponade and the word tampon have the same origin, from a French word that means to plug or to tamp or to reduce or to lessen or to press on and reduce. Example, suppose that I was hanging around with bad friends. Some of them stabbed me with a knife through my skull. Oh! So I went quickly to the emergency room. Lucky for me, the person who first met me was a freaking medical student or a first-year resident. Oops, what do you think the medical student will do? Oh, medicosis, let me help you. Let me remove that knife for you. Doofus, that's a bad mistake. Because if you remove the knife from the skull, a sudden gush of blood might ensue and I may collapse from a hemorrhagic hypovolemic shock. In other words, the perpetrator did not kill me, but the medical student did. What did I do wrong then? Why are you yelling at me? Well, this knife is providing a tamponade effect. If there is bleeding inside, the knife is stopping the bleeding in its place by putting pressure, i.e. tamponade, on the broken blood vessels. Removing the knife will remove this tamponade effect that reduces and lessens and plugs the bleeding. That's why I can collapse. Oh, so we're gonna leave it there forever? No, you are going to remove it only in the operating room when I'm under anesthesia and ready for the operation. So that if a disaster ensues, we are well equipped to supply blood. We have a cardiac monitor, we have a freaking anesthesiologist, and a surgeon. And this is the beauty of the tamponade effect. Why do we call the tampon? Now you know. And why is cardiac tamponade called cardiac tamponade? Because it is a plug, it's a pressure, it tamps the heart. It puts pressure on the heart. And there is another tamponade in medicine, balloon tamponade for esophageal paresis. Let's put pressure on those bleeding varices so that they do not get worse. Back to basics, here's the heart, 3 layers in the wall of the heart. The inner layer is the endocardium. The word endo means inner, and this is the layer that has the heart valves. And that's why endocarditis causes what? Murmurs. It has to be a new murmur, something new, because I developed new endocarditis. Then I have my myocardium, which is the muscle layer of the heart. Cardiac muscles have troponin inside the muscle cell, so any inflammation or infarction of the muscle cells will lead to what? Release of that troponin into the blood. Elevated serum troponin is seen in cases of myocarditis or myocardial infarction. Can pericarditis cause elevated troponins? Well, if the pericarditis also includes myocarditis, i.e. myopericarditis together. In that case, it can elevate my serum troponin. The moral of the story is just because the patient has high troponin doesn't necessarily mean that it's a myocardial infarction. It could be myocarditis, it could be myopericarditis, and other causes. The pericardium is the outermost layer of the heart. But what is the epicardium then? Please comment below. In the last video, I've told you about the types of pericarditis. We can classify it in numerous ways. You can say I have dry versus wet, i.e. pericarditis that is dry or pericarditis with effusions. These effusions could be bloody hemopericardium, they could be pussy seropericardium, they could be watery hydropericardium, or they could be lymphy chylopericardium. And then we can classify it in another way. You can say acute pericarditis versus chronic pericarditis. Acute pericarditis could be the non-specific idiopathic pericarditis, or could be infectious pericarditis, including bacteria like tuberculosis. Sometimes fungi can cause this as well, such as systemic disseminated coccidioidomycosis. Viruses can cause it too. If I have an infection, I will usually have pericardial effusion that is exudative, pussy, seropericardium. How about malignancy? Same, exudate as well. But what if it's cirrhotic nephrotic CHF? The pericardial effusion will be more watery, called transudate, called hydropericardium. Exudate is protein-rich, transudate is protein-poor. Exudate is cell-rich. Transudate is cell poor. What kind of cell are we talking? Neutrophils, of course. Pus cells are literally neutrophils. And neutrophils secrete what? Well, they have granules, so they will secrete their granules when they get excited. Oh, and these granules are what? Mostly proteins. And that's why exudate is protein-rich. But in transudate, no neutrophils, which means protein-poor and cell-poor. See, medicine makes so much sense once you understand what the flip you're talking about. Next, if you stabbed my heart, hemopericardium, that's blood. If I injured my thoracic duct, I get lymph, chylous effusion. All of this could be acute pericarditis. How about chronic? There's chronic adhesive pericarditis. There is also chronic constrictive pericarditis, which was the topic of the last video. And we talked about my C mnemonic in that video. Your pericardium is naturally stiff and resilient, and that's why if a few drops of fluid accumulates there, nothing will happen. You will suffer no symptoms and everything will be hunky-dory. If it happens over a long period of time, chronic pericardial effusion, it gives enough time for the pericardium to distend and stretch a little and accommodate that fluid, so you will have no symptoms. However, if the accumulation of fluid in my pericardial sac happens acutely and severely, too quick and or too much, what's going to happen? There's no enough time for me to distend and accommodate. So that fluid will compress my heart, and that's the tamponade effect. This is what we call cardiac tamponade. Who will suffer the most, the left side of the heart or the right side of the heart? Guess what? The right side of the heart. Why the right side? Because the right side has lower pressures compared to the left side of the heart. Let's draw a simplified version of the heart right here. The blue is the right side and the left is the red side. And here is my septum in between. The pressures on the right ventricle are lower than the pressures in the left ventricle. So the left ventricle can take it, but right ventricle will have trouble accommodating all of that compression. So I'll have problems in the right side more than the left side. But make no mistake about it, both of them will suffer. What am I trying to say? I'm trying to say that just because I have pericardial effusion does not necessarily mean that I have a cardiac tamponade. Cardiac tamponade is a special case when the fluid accumulates too quickly or too much fluid to the point that it raises the filling pressure suddenly. What's the filling pressure? It's the pressure needed to fill my heart. Oh, but if I'm surrounded with blood all over, as in traumatic pericardial tamponade, well, it needs more pressure to overcome the pressure of the tamponade in order to fill the heart. This is called rising of the filling pressure. What are the causes of cardiac tamponade? We have acute causes most of the time. We can also have subacute causes. Sometimes even chronic causes. Let's start with the acute. Trauma, whether penetrating or blunt. Penetrating is like when you stab me with a sword or a knife. On the other hand, blunt is like hitting the steering wheel of my car during sudden deceleration. Both are bad, it's just that the physics is a little different. Next, aortic dissection, especially in Stanford type A. Remember that Stanford type A was way worse than Stanford type B. For Stanford type A, we go to surgery because this involves the ascending aorta, which has the coronary arteries. Not good. But for Stanford type B, you can give beta blockers, control the risk factors, and call it a day. So Stanford type A is way worse. Aortic dissection could be retrograde. What does that mean? Here is the wall of the aorta like this, and here's the dissection. The dissection is moving backwards, 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 backwards until pew, we puncture the aorta, and all of that blood will seep into the pericardial sac around the heart, and that's a tamponade for you. If it happens too quickly or in a big amount of blood. How about free wall rupture of the ventricle after myocardial infarction? After myocardial infarction, what happens? Well, the heart cells are literally dead. My myocardium is toast, which means cell death, which means this part of the heart that has the infarction will be weaker. And we still have pressure inside the heart. This pressure can push to the outside until I rupture the wall. How about after surgery? As in coronary artery bypass graft surgery or valvuloplasty surgery. Yeah, after cardiothoracic surgery, I can develop a cardiac tamponade as a complication of the surgery. How about if I have pericardial effusion, especially if they are too much, or if they can accumulate quickly, such as uremia from kidney failure, cancer, let's say I have breast cancer that metastasized to the pericardium, or infections like the nasty miliary tuberculosis. Remember that primary tuberculosis does not affect the heart, but secondary tuberculosis, disseminated tuberculosis, of course, can affect my heart. Primary tuberculosis can only affect 4 organs in the body. Do you know what they are? Please comment below. You'll find the answer in my video on tuberculosis. How about after viral infections, tuberculosis infection, other bacterial infections, fungal infections? Can I get tamponade? It can happen, especially if it happens too fast or too much a fluid. After exposure to radiation, I can develop tamponade. After ablation, I get inflammation and then exudative pericardial effusion. If it's too much, I can get a tamponade. Iatrogenic. What does genesis mean? Oh, creation. Okay. Iatros means the healer, created by the healer. Who's the healer? You, the doofus doctor who injured and punctured the right ventricle during the placement of a central venous line. Well done. So first you removed the knife from my skull in the hallway of the hospital and I collapsed. Then you made another mistake by perforating my right ventricle while placing a central line. That's not a good doctor. That's just a doofus with a stethoscope. Please don't be one of these. You can download these doozy notes on my website, medicosisperfectionalis.com. If you really want to understand the hemodynamics of cardiac tamponade, please get a pen and paper and doodle with medicosis. You will need a blue pen and a red pen. Let's get started. Okay, how many hearts do you have? Oh, I have only one heart. Oh, shut the French toast up. This is all nice and dandy if you are a biology student. But if you want to learn medicine or physiology, you gotta look at your heart as 2 separate hearts. You have the right heart and the left heart, with an abyss separating the two, and this abyss is the interatrial and interventricular septum. What happens in cardiac tamponade that I have lots of fluid in my pericardial sac around the heart, and this can happen acutely or a large amount of fluid. And that fluid could be blood, could be pus, could be water, could be lymph, etc. I don't care. Who will suffer earlier, the right side of the heart or the left side of the heart? The right side will suffer first. Okay, now I want you to look from the perspective of the poor superior and inferior vena cava. Let's look at the inferior vena cava. Hey, inferior vena cava, why don't you send some blood to the right atrium? Okay, let me try. Oh, I couldn't. There's too much pressure there. There's too much resistance. There is too much fluid in the pericardial sac. I couldn't do it. What's going to happen to the filling of the right side of the heart? There is decreased filling on the right side of the heart. So what's going to happen to the preload on the right side? The preload on the right side will decrease, and the preload is synonymous with end diastolic volume, which is the volume in the heart at the end of diastole. Since I am unable to fill the heart properly, the EDV will decrease because the preload decreased, which means I am filling the right side of the heart with less blood. So the volume of filling decreased, but what's going to happen to the filling pressure? Oh, it's the pressure needed to fill the heart. No, that filling pressure went up because I have to overcome the resistance caused by the fluid accumulation. High resistance means high pressure, because remember that the blood pressure equaled what? It was cardiac output times total peripheral resistance. So between resistance and blood pressure, there is a direct relationship. When resistance goes up, pressure goes up. Here's the resistance caused by the fluid. So the pressure of filling will go up as well. And you can remember Boyle's law. If the temperature is kept constant, and it is constant in your body, when pressure goes up, what's going to happen to volume? It goes down. See, it makes perfect sense. Next, let's talk from the perspective of the poor right ventricle. Okay, right ventricle, what's going on? I was trying to give you some blood. Now, can you relax during diastole and accept all that blood? Okay, let me try. Well, oops, I tried to relax, but I'm surrounded with blood all over. I could not relax well during diastole, which means I could not fill with blood. And this is what we mean by preload decreasing. So what's going to happen to the blood that I could not accept? It will have to pool and pile up somewhere else, such as in the right atrium. And then somewhere else, such as superior vena cava, which communicates with your internal jugular vein. So I'll get what? Tons of blood in the internal jugular vein. What do you call this? Jugular venous distension. So what happened to my jugular venous pressure? It increased, and since the internal jugular vein is communicating with the right atrium, which is the biggest vein of the body, so to speak, because it receives blood from the superior vena cava and the inferior vena cava, so that's the center of them. It's the central vein, it's the biggest vein, so to speak. So what's going to happen to my central venous pressure, please? It also went up. The central venous pressure increased for the same reason the jugular venous pressure increased, which is that the right ventricle could not relax during diastole and accept all that blood. If this is bad enough, all of that blood can also pool around my liver, causing hepatic congestion. Now that's the story for the right side of the heart. Now get your red pen and let's talk about the left side of the heart. When you were young and tender in physiology, you used to say preload and afterload, but this is not acceptable anymore. You gotta be more specific. Preload of what? Is it preload for the right ventricle or preload for the left ventricle? Because they are not necessarily the same in someone with a disease. So here we're talking about the preload of the right side in a blue color. Now let's talk about what happens to the preload of the left side. Let's think about this. Here is my left atrium. It should accept and receive blood from the pulmonary veins. Okay, hey pulmonary veins, try to give your blood to the left atrium. Okay, let me try to give this oxygenated blood to the left atrium. Oops, I'm surrounded with tons of fluid. There is too much resistance. I could not give as much. And hey left ventricle, could you relax and accept the blood during diastole? I tried to relax, but I hit a bunch of fluid. Oh, I could not relax. So what's going to happen to the preload on the left side? It too decreased. So what's going to happen to the blood? It will pool up here in the left atrium. And then it will pull into the pulmonary veins and the pulmonary capillary. So what's going to happen to the pulmonary capillary wedge pressure? The pulmonary capillary wedge pressure increases. Would you like a tip for the pros? Yeah. The pulmonary capillary wedge pressure is the left atrial pressure, but the central venous pressure is the right atrial pressure. And this will save you a lot of points on your exams and will help you be a better doctor, not another doofus with a stethoscope. And this is the importance of talking about the preload of the right side and the preload of the left side of the heart separately. When this blood reaches my lungs, can I get some cough? Of course. How about some dyspnea, shortness of breath? Absolutely. Then what? I want you to think of a factory. If there is less input to the factory, what's going to happen to the output of the factory? It will also decrease. So what's going to happen to the output of the heart, aka cardiac output? Well, cardiac output will decrease because the cardiac input, the preload, also decreased. Less input, less output. Garbage in, garbage out. Now please help me. You remember that the blood pressure equals cardiac output times total peripheral resistance. Cardiac tamponade is not a disease that affects the resistance of the arteries in your arm. For example, the brachial artery is fine, the radial artery, ulnar artery, femoral artery, they are fine. So the resistance of the vessels is okay. However, what happened to the cardiac output here? Cardiac output decreased, and therefore the blood pressure will decrease. Okie dokie, blood pressure goes down. The next point requires you to go back to those physiology days. Do you remember something called the baroreceptor reflex? Yeah. When the blood pressure decreases, the brain gets upset because this means less oxygenated blood reaching my carotid and reaching my aortic arch. The brain feels the drop in the blood pressure and the brain gets mad, gets super excited. I will send my sympathetic nervous system to put everything on fire. I'm gonna raise the heart rate to try to increase the blood pressure. Because remember, when I raise the heart rate, I raise the cardiac output. When I try to raise the cardiac output, I will try to raise the blood pressure back to normal. Okay, what else does the sympathetic do? The sympathetic can also constrict vessels, arteries and arterioles. When I constrict arteries and arterioles, what's going to happen to the TPR? The TPR will increase. Why did you increase the TPR? To try to bring the blood pressure up and back to normal. What do you call the patient who has hypotension, poor tissue perfusion, and tachycardia? In a state of shock? Yeah, hemodynamic instability. It is a shock. What's the name of this type of shock? Is this hypovolemic shock? Is this constrictive shock? Is this distributive shock? Or cardiogenic shock? Or what? The answer is, this is obstructive shock. I am obstructing the heart. That's the definition of a tamponade. If the cause of the tamponade is bleeding, such as someone stabbing me to the knife in my chest, it could also be considered hemorrhagic or hypovolemic shock. Now you understood the pathophysiology and the hemodynamics, let's talk about the clinical examination. Dullness around the heart could be appreciated because of the tamponade, because of the fluid. Now bring your stethoscope and listen to the heart. I cannot hear anything. I can barely hear S1 and S2 heart sounds. Why not? Because the fluid is coming in the way between my beautiful stethoscope right here and the actual heart, which means I'll have distant, muffled, diminished heart sounds. When your patient has jugular venous distension, hypotension, and muffled heart sounds, this is called the Beck's triad. Next, let me take in a deep breath. Okay, deep breath coming in. Oh, right ventricle tried to relax this way, but there is lots of fluid this way. So the right ventricle will press on the interventricular septum to push onto the left ventricle, which means during inspiration, my systemic blood pressure, which is a product of the left ventricle, will decrease by more than 10 millimeters of mercury, a phenomenon known as Pulsus Paradoxus, which is neither Pulsus nor Paradoxus. It's the worst misnomer of all time. Lots of fluid will reach the lungs, correct? So percussion of the lungs will be dull, especially on the left lung. Why the left lung? Because also remember there is dullness to percussion caused by the tamponade. And your heart, although a central organ anatomically, it has its apex swinging to the left side in the vast majority of people. So the dullness on the left lung will be more than the dullness on the right lung. How about the tactile vocal fremitus on the left lung? It will be increased. Why did it go up? Because remember, fluid is better at conducting sound waves, mechanical waves, than air is. That's why the tactile vocal fremitus, TVF, on the left lung especially, will go up. What's that called when there is tactile vocal fremitus elevation on the left lung and dullness to percussion, especially on the left lung? This is called Ewart sign. Who else is gonna teach you this? Your professor with his PowerPoint? Give me a break. Let's do an ECG. Okay, let's do it. Place the electrodes on the patient's chest. Okay, now look at the EKG recording. Well, some recordings are high amplitude, some recordings are low amplitude, then high amplitude, then low amplitude. Why is this? Because the heart is literally dancing in fluid. So sometimes it gets closer to your electrodes, high amplitude. Sometimes it gets far away from your EKG electrodes, low amplitude. High amplitude, low amplitude. High amplitude, low amplitude. A phenomenon known as electrical alternanse. Not to be confused with pulsus alternans. Pulsus alternans is a phenomenon of the pulse, but electrical alternans is a phenomenon on the ECG. And this was the best discussion of cardiac tamponade in the history of the world. But we're not done yet. Let's review. Right side is toast with low preload, decrease in diastolic volume. So what do I get? I get jugular venous distension. I get increased central venous pressure. And in severe cases, I can get hepatic congestion. On the left side of the heart, there is also decreased preload. So the blood will pool and pile in the left atrium, increase pulmonary capillary wedge pressure. Less input equals less output. And then you put the stethoscope, you find distant, diminished heart sounds. And when I have a triad of jugular venous distension, hypotension, and muffled heart sounds, this is the Beck's triad. Pulsus paradoxus can happen in cardiac tamponade, but Kussmaul sign is extremely rare in cardiac tamponade. But it was relatively more common in constrictive pericarditis. The difference between Pulsus paradoxus and Kussmaul sign was discussed in detail in the previous video on constrictive pericarditis. Let's start with Pulsus paradoxus, which is neither Pulsus nor Paradoxus. It's the biggest misnomer of all time. It has nothing to do with pulse. It has to do with your blood pressure. It is not a paradox. Instead, it's an exaggeration of a normal phenomenon, because normally during inspiration, because the right ventricle pushes on the septum and pushes on the left ventricle a little, you get decrease in systolic blood pressure by less than 10 millimeters of mercury. But if it's more than 10, this is the exaggeration of the normal phenomenon, inappropriately termed Pulsus paradoxus. As for the Kussmaul sign, this has to do with your neck veins. Normally, during inspiration, the neck veins empty into the right atrium. But what if the heart is surrounded by fluid or surrounded by a very thick pericardium, as in constrictive pericarditis? In this case, inspiration can lead to jugular venous distension, because the jugular veins could not empty into that heart which is surrounded with fluid. What's going to happen to the size of my right atrium if I have cardiac tamponade? It will diminish because of all the pressure surrounding it. Remember the pressures in my chambers? Yeah, you go by coins. I have 5 cents, and then 10 cents, and then 25 cents, and then a full dollar. The dollar means 120 millimeters of mercury. Here is a nickel, here is a dime, here is a quarter, here is a dollar. These are systolic pressures. How about diastolic pressures inside my chambers? All of them are almost zero. I did not say exactly zero, but almost zero. In the right atrium, the diastolic pressure can even become negative, so that we can suck blood in from superior vena cava and inferior vena cava. Now let's look at the right side of the heart and compare it to the left side of the heart. Which one has higher pressures? Well, here is 525, but here is 10, 120. So the pressure in the left side is higher than the pressure on the right side. So which one will be compressed more and affected more in cardiac tamponade? Of course, the right side will suffer more. And this is actually seen on echo. If I have cardiac tamponade, what will I see on EKG? A phenomenon known as electrical alternanse, which means here is a QRS that is normal amplitude, followed by low amplitude, then high amplitude, then low amplitude, then high amplitude, then low amplitude, low, and then high, and then low, and then high, and then low. Why? Because the heart is dancing in fluid. Sometimes the heart comes closer to your electrodes, and sometimes it gets far away from electrodes. Closer, further, etc. Dancing in fluid. And what will I see on echocardiography? Collapse of the right atrium and the right ventricle because of all of the fluid and because the right side has lower pressure. And the right side will press onto the septum. Try to push the septum towards the left side. So I will find that I have shift of the interventricular septum towards the left. And this is why we develop Pulsus paradoxicus. What kind of shock can happen to a patient with acute severe cardiac tamponade? It could be hemorrhagic hypovolemia. Why? Because I was stabbed with a knife. Or it could be obstructive. On your exam, if you have to choose, you go with obstructive, baby. Is this problem coming from within the heart? No, it is fluid surrounding the heart from the outside. So it's extracardiac obstructive shock leading to hemodynamic instability, such as low cardiac output, low blood pressure, high heart rate, shortness of breath, cough, etc. There are many causes of obstructive shock. One of them is cardiac tamponade, another is constrictive pericarditis. Aortic stenosis can do it if it is severe enough, tension, pneumothorax, massive pulmonary embolism, and anterior mediastinal mass. If you have watched my video on aortic dissection, you would have learned that we have tons of complications. One of them is that the aortic dissection can go backwards from here to here until I bleed into my pericardial sac and develop cardiac tamponade. The complications of aortic dissection are very high yield for your exam. Let's summarize what we've learned about cardiac tamponade in one big slide. Causes: trauma, aortic dissection, rupture of the free wall of the left ventricle after myocardial infarction, post-cardiothoracic surgery, pericardial effusions, and post-radiation, or post-puncturing my right ventricle during the insertion of a central venous line. Your pericardium is naturally resilient and stiff. For me to have cardiac tamponade, either it has to happen very quickly or in a very big amount of fluid. Hemodynamics: preload on the left side and the right side decreased. Stroke volume decreased, cardiac output decreased, so my blood pressure will decrease. When my blood pressure decreases, baroreceptor reflex, I'm gonna raise the heart rate, I'm gonna constrict vessels, which makes me in a state of shock. The pressure in the right atrium goes up, this is called central venous pressure. The pressure in the left atrium goes up, and this is the pulmonary capillary wedge pressure. The size of the right atrium decreases. Why? Because it has been compressed. Don't forget the famous Beck's triad, 3 Ds. distension of jugular vein, diminished blood pressure, distant, diminished heart sounds. Try to feel the cardiac apex with your fingertips. It's diminished as well. Why? Because there are fluids separating your fingers from the patient's cardiac apex. The patient may have chest pain, may have pallor, look at the hypotension, shortness of breath, look at the high pulmonary capillary wedge pressure, orthopnea, dysphagia, because remember that your esophagus is behind your heart. If I have tons of fluid around the heart, it can press on my esophagus, causing dysphagia. Hoarseness of voice, because pressing on the recurrent laryngeal nerve. How about hiccups? They can happen too. Vagus, baby. Don't forget that the vagus nerve supplies the heart. During inspiration, I can get Pulsus paradoxus. Kussmaul sign is rare in cardiac tamponade. Ewart sign happens in the left lung, L-E-F-T. Tactile vocal fremitus is elevated on the left lung. Percussion is dull on the left lung. And sometimes I even have bronchial breath sounds. Do an EKG, electrical alternanse. If you have all of this, you know your diagnosis. Do not wait for more tests. Instead, you should go to treatment. But what if I'm not certain? What if I do not have all of these symptoms clear? Do an echo. If your exam question said which of the following is the most appropriate next step and you answered chest x-ray, that's the wrong answer. So you're saying that chest x-ray will be normal? No, I did not say this. I said chest x-ray is not the next step. The next step is echo and then treatment. What are the findings on chest x-ray? Enlarged cardiac silhouette, because the heart is filled with fluid in the pericardial sac. When the diagnosis is not certain, we do an echo, such as transthoracic echo. If this is a trauma setting, it's called the eFAST, which checks for fluid accumulation in the thorax and the abdomen. What will I see on echo? Collapse of the right ventricle and the right atrium, plethora of the inferior vena cava, because we could not push that blood towards the right side of the heart because of all the tamponade, and we see shift of the interventricular septum towards the left side. What will I see on EKG? Electrical alternanse. What else? The QRS amplitude is shorter than normal, even the one that seems taller than the next one. So we see big and small and big and small. Even that tall one is not as tall as it should be. Why is it shorter than it should be? Because I have all the fluid around the heart coming in between my heart muscles and the electrode on the patient's skin. If the question asked, which of the following is the most accurate test to confirm the presence of cardiac tamponade, the answer is catheter pericardiocentesis. It will show you fluids around the pericardium, proving that this was a tamponade. It's also therapeutic because it will remove the fluid from around the heart, and you should do this under echo guidance, so that you don't end up rupturing my right ventricle again. If you did not see pericardiocentesis as an answer choice for the management of cardiac tamponade, pick pericardial tube. But if the question said that this patient had pus in the effusion, or chronic or repeated attacks of tamponade, it's time to perform a surgical pericardial window to prevent that fluid from piling up back again. When everything hits the fan, you can perform surgery known as open thoracotomy. And this might be needed if the patient has fluid that could not be drained by a tube, if it has loculations, fibroses, etc. A very important point to remember for your exam: try to avoid positive pressure ventilation at all costs. Why? Because this is positive pressure, which means it increases intrathoracic pressure, which means it's going to press more on my poor heart, and the poor heart already has fluid around it, so this will decrease the preload further. Less input equals less output. Cardiac output will worsen and the blood pressure will decrease even more. You can download all these doozy notes on my website, medicosusperfectionalis.com. Quiz time. I have many questions for you. Please let me know your answer in the comments. First question, please list 5 diseases that can cause all of the following findings together. I want diseases that cause jugular venous distension with hypotension with Pulsus paradoxus. The answer key will be in the next video. Next, here's cardiac tamponade. Tell me, what happened to the filling pressure? How about stroke volume, cardiac output, blood pressure, heart rate, total peripheral resistance, central venous pressure, pulmonary capillary wedge pressure, cardiac index, and the saturation of the venous oxygen, also known as mixed venous oxygen percent saturation. Another question, what is the name of this physical exam finding? Comment below. Last question, can you please compare between constrictive pericarditis and cardiac tamponade based on the following points of comparison? In the next video, we will compare between constrictive pericarditis and cardiac tamponade. But I want you to practice this on your own before watching the next video in this cardiology playlist. If you want to learn about angina, myocardial infarction, many arrhythmias, acute respiratory distress syndrome, diabetic ketoacidosis, drowning, hypothermia, hyperthermia, and much more, download my emergency medicine high yields course at medicosusperfectionalis.com. To master cardiac pharmacology such as anti-hyperlipidemics, antiarrhythmics, anti-angina, antihypertensives, diuretics, and even freaking digoxin, download my cardiac pharmacology course on my website. There are more than 300 premium videos. In order to access them, please click the join button and choose the highest tier. Subscribe, smash like, hit the bell, support my channel on Patreon, PayPal, or Venmo. Go to my website to download my courses, notes, and cases, or if you'd like me to personally tutor you. Be safe, stay happy, study hard. This is Medicosus Perfectionalis, where medicine makes perfect sense.